Fats. Yeah, welcome everyone. Welcome to the Fats Regenerative webinar. Today, we are very honored to welcome a very good friend and Professor Lin Tsai-Ming from Taiwan to share his experience and with his topics today is combining regenerative and aesthetic medicine, the role of fat grafting. Okay, so today this lecture will have a 30 minutes lecture, after which we have a Q&A for 15 minutes. Okay, so with that, I leave the floor to Professor Lin. Professor Lin, you can start sharing your screen.
Okay. Good. Okay, can anyone hear me?
Yes, we can hear you loud and clear, Professor.
Okay. Good evening. Right now in Taiwan, it's about 7 o'clock. It's my great honor to be here and to talk each potential participants of FEDS this year, Bangkok 2024. And my topic will be combined regenerative and aesthetic medicine, the role of fat grafting. This is my disclosure. As you might heard about that, I'm the inventor of MapGum. Actually, I'm a plastic surgeon. I do many plastic surgery in my past career. Since I have MapGum, we publish many articles and of course with some video, and my own textbook will coming up this year. As you can see that the beginning of 21st century is marked considerable progress in regenerative medicine, driven by intensive research into stem cell. And I use this presentation in memoriam of Professor Arnold Kaplan. As you know, is reputed as the father of both basic and clinical therapies of adult MSC, mesenchymal stem cell. And actually, early, almost in the same era, the Polton in 1990 concluded that stem cells should have the ability to proliferation, and they can cell maintenance and have the production of large number to differentiate and functional progeny. And of course, it is induced to repair or regenerate the tissue after trauma. And of course, there are some flexibility to use clinical. And almost 60 years after 1990, the ISCT, International Society of Cellular Therapy, further defined the mesenchymal stem cell. First, adhere to plastic dish in standard culture. Second, expression of specific cell surface marker like CD73, 90, and CD105. And the third is the capacity to be induced, differentiate to osteoblast, chondrocyte, adipocyte, something in the mesoderm, embryonically. We all know that from bone marrow, we can have so-called hematopoietic stem cell. And of course, there are some stroma cell. So we mean it that you can harvest some bone marrow and have mesenchymal stem cell. And according to the definition, as mentioned earlier, the MSC could be differentiate to adipocyte, osteocyte, and chondrocyte. So traditionally, MSC are found from bone marrow. However, the group of Ethan Case and Mark Hedrick isolated MSC from a new reservoir in human adipose tissue, as demonstrated in this article in 1999, and they gave the term of SVF, stroma vascular fraction, which in this slide, you can see that it composes so-called pre-adipocyte, endothelial cell, and so many other cells. It's a mixed heterogeneous cell bank. And 2 years after, in 2003, Zook and Hedrick, almost the same group, further demonstrate that adipose tissue is a source for MSC, of course. However, it will have notably longevity, multiple potency. Therefore, it significantly advanced the field of autologous fat-derived stem cell research. And as this slide showing you that after harvest of fat, and of course you can use it anywhere you can, like you excise adipose tissue and trimming to a small pieces, or you use the ordinary way to lipoaspirate, then you apply some collagenase and repeat wash it, and finally you get some so-called the stroma vascular fraction, in the bottom, and of course in some other there, they will compose some purified fat or some oil or something else. And by this way, you can find that the small vascular fraction is just a pellet. It's something very congregate. So all these cells, including stroma cell, pericyte, endothelial cell, and so many other like T cell, macrophage, will aggregate in a fine pellet. In 2006, Dr. Yoshimura Kotaro reported cell-assisted dipole transfer, CAL. And the CAL offered a novel method for soft tissue augmentation by combining aspirate fat. Then you use collagenase to get the adipose-derived stem cell and to improve the fat survival. And this technique supported by successful animal study that ASC not only enhance fat grafting survival by promoting vascularity, but may also differentiate to various tissue cells like adipocyte. So this is improve the efficacy and safety of autologous fat transfer in clinical applications. On the other hand, to echo my topic, fat grafting, we all know that in 1893, almost 131 years ago, the Newberg first introduced the fat graft. And 2 years after, Journey using a back lipoma to restore some removing tumor in some patient due to mastitis. And in 1980s, there are so many instruments and concepts introduced by Fournier and Illouz. And this innovation, liposuction, transfer how autologous fat was acquired. So at that stage, the fat grafting become very popular because it's easy to get fat and easy to inject. This is veneer and loose. At that stage, they might be used only using some negative pressure without any tumescent, and of course, it will be modified years after that. However, in the history of liposuction, someone say that Dr. Fisher, actually a gynecologist, invented liposuction in Rome, Italy. But all this is history, and all this mental contribute quite a lot. But for us, the clinical doctor, we care so much about the survival rate. Like in the very beginning, Newberg and Peer pointed that only 55 fat survive when you're doing the fat grafting, meaning that maybe you think about you will inject more to increase the survival or retention rate. And talking about the transplantation way, I think the most popular one is to overinject, because under the influence of peer is only 50% survive. So you're going to overinject and you massage it vigorously and to make the service phrase to increase the retention rate. Something like in this animation, you can see that there is a soft tissue defect and you inject fat, maybe 2 push, 3 push. Anyway, you want to make the place to a little bit large, then you massage it to make the surface flat. However, this is a false symmetry, end up with also central necrosis and induce some morbidity like asymmetry, nodulation, and fibrosis. And there are two mentors in my eye who contribute quite a lot. The first is Carpenter in 1993, and the second is Coleman, present the structural fat grafting. Let me introduce more. As you know that Sidney Coleman is reputed as the modern fat grafted father. So he contributed quite a lot and present the structural fat graft and insist that each puzzle, when you push the syringe, should be small in 1 to 50 to 1 over 30th. Because if you inject too much, the central will become necrosed. And after that, all the complication related to central necrosis will happen. And Carpenter observed in rabbit animal model that many of the fat will necrose in the central. And from the peripheral to the central, it's around 1.5 plus minus 0.5 millimeter will survive. And we use this slide to share with you. If the puzzle too large, the peripheral will survive because it's easy to get neovascularization, or some in the very beginning, initial 48 hours, diffusion or plasmatic inhibition. But after that, the central area, the adipocyte cannot get neutralized. Neovascularization will not occur in the central zone. So the central zone will become necrosed. And when we look back, this is the procedure of fat grafting from harvest, refine, process, and transferring. And I think in my eye, the placement is the most important thing, because for short of a success, for lack of final efforts. So if we can do in a mathematical calculation, when a spherical, like a fat puzzle is radius 1, the volume will be 4.2 millimeter cubic. So 1 cc equal to 1,000 millimeter cubic divided by 4.2, which is spherical with radius 1 millimeter, equal to 240, meaning that there will be 240 parcels at radius only 1 millimeter in 1 cc. And very similarly, there will be only 30 parcel in the area in the volume of 1 cc if the radius is 2 millimeter. So in 2007, I proposed my concept of microautogenous fat transplantation based on the study of Carpenter and Coleman. And I wish each of the parcel should be smaller as possible as you can, like not only 1/50th or something like a Carpenter to avoid the central necrosis. And I wish to reach a small parcel with radius only 1 millimeter, very, very tiny. So there will be 240 per parcel in 1 cc if the radius is 1 millimeter. So my hypothesis is very simple to avoid the central necrosis. And we have our prototype of MapGun in 2007. Then we get patent and certification of Taiwan FDA and US FDA and CE marking. And right now we have 3 generations. The 3rd generation one is the update now. And for the past almost 15 years, personally, I have more than 6,000 cases from the hand, face, neck, to many others like augmentation mammoplasty or reconstructive breast surgery. So these 2 articles detail the technique in the sunken eye. And this is article from our publication for the forehead and temporal sunken recontouring. And this is again the textbook. And of course, this is for nasal dorsum, hand beautification, combined with other like low blepharoplasty. And we find very magic recontouring of gummy smile. And we also have some idea of Asian profile-plasty for the nose rhinoplasty and chin augmentation mentoplasty. And we also very experienced in periorbital rejuvenation for Asia. And in short, the mouth is manual aspirate, and I doing the centrifugation at 1200 G for 3 minutes. I get the purified fat from the middle and loading to 1 cc syringe and lock to mouth gum. And this is something I want to share with you. You use your hand to inject 1 cc. Maybe you try to avoid a large one. So you must be very careful to control your power when you inject. And this is in the table without any resistance from human tissue. However, if you want to inject that small, like 1/30th, it's kind of not easy to achieve because they are always moving by your hand. They are always resistant from the tissue. So you cannot inject like I showing you in this video consistently. However, as you can see that using mouth gum, you just pulling the trigger. And now with the advance or the plunger is fixed. So there will be fixed volume like from 1/60th. And right now I inject in 1/90th. And all the way according to different location of your recipient side. Like in the forehead, temporal, you might inject 190 or 120. And in very thin skin, like a sunken eye or teardrop or nasal dorsum, you might switch to 1 over 240 or 1 over 180. So it's something very consistently control the volume you want to deliver without any mistake or any misinjection for a single large puzzle. So this is the tiny one. It's 1 over 240 cc for each puzzle. So actually, when you withdraw the gun, you can pull in the trigger continuously. So there will be a sausage shape or a sling, a strip, like a spherical. And as you can see that when you change the size, the cylinder becomes thinner from 1 over 60 years to 1 over 240. And of course, right now we have the automatic map gun. So you don't have to keep pulling the trigger. So you just holding on the trigger to make the automatic map gun on the on situation, the puzzle will deliver to pulling out. So this is quite innovative and cutting-edge device. And let me show you very briefly. This is for the total facial rejuvenation. Left side pre and right side post, combined with slow blepharoplasty, in the neck rejuvenation, in the hand purification. The upper is the both hands, and lower is 3 years after. And this is one section for breast augmentation. Actually, this is two sections with nipple-plasty for augmentation mammoplasty. This is for gummy smile by inject to the nasolabial fold, the echo tri, and the upper lip. And this is something interesting that after mastectomy, she's a victim of breast cancer. You can see that hyperpigmentation with some ptosis and fibrosis of right nipple. And after one section and after two sections, almost recover all the appearance, especially the right side. And of course, you can do the augmentation mamoplasty at the same time in her the healthy side. And this is something the hemifacial microsomia that the patient suffering from atrophy of her left side face. This is after one section of fat grafting. And this is a victim so-called perirhombar syndrome. So the perirhombar syndrome is quite common thing in female have the symptom about the teenage and progress. Like you can see that fibrosis of the soft tissue and some bone irregularity, even have some alopecia. This is something after one section, 3 months, not only the recontouring, but also the alopecia will improve after fat grafting. So this is from contour to rejuvenate. And we cooperated with some ENT doctor. We can inject the fat to the vocal cord area. As you can see, this is vocal cord palsy due to some atrophy, aging, or some misuse of your vocal cord. End up with, you can see that the vocal cord become healthy and can close almost completely. And this is, again, I want to share with you from contouring to rejuvenating and also to eliminate some scar contracture. And this is, again, some ethnic scar. and from the recontouring to rejuvenation of the skin texture. And this is also showing in the right cross-fit area, fine wrinkle, and hyperpigmentation. And this is 4 years after sunken eye correction and dark eye syndrome. And this is another case we apply fat grafting to accelerate the wound healing. This is after traffic accident, deep second degrees. This is the operating time. We inject some fat under beneath the wound. This is 7 days. This is 10 days. This is almost 1 month after. You can see that all the wound here almost in the 10 days. And after complete here, the fibrotic and the scar become very invisible. So I must come to a conclusion. With your hands, if you're doing fat grafting, you cannot consistently deliver the fat. With the mouth gun, of course, you can do without any difficulty. So in conclusion, the integration of regenerative and aesthetic medicine through the innovative use of fat grafting and through the combine of so-called the adipose stem cell and the MAFT technique. And the synergy is not only enhance the clinical outcome, but also broaden the scope of treatment available, something like I showed you in the vocal cord area. And we were going to have a promising future where regenerative medicine and aesthetic enhancement coverage to offer a novel solution for our patients. So we need this high technique, not only in advanced like a tissue culture or some isolation from the adipose tissue, but we need some very basic technique for transplantation. So working together, meaning that the synergy. How to work together? I think please join our first meeting in Bangkok for 2024. And this year we highlight, regenerative revolution from science to practice. And I look forward to seeing all of you in Bangkok. And thank you very much for your attention.
Okay. Thank you very much, Professor Lin, for your presentation. And with that, you are open up the floor for questions. You can raise up your hand if you want to ask direct questions, or you can put your question in the Q&A and the chat group. Maybe I have a question, Professor. I saw in one of the slides that one, I think maybe the latest generation of your MEF gun that is, I saw, is it an electrical injector?
Yes.
Oh, so for that, is it
Yes.
available already in the market?
Yes.
Oh, okay.
Yeah. We have got the patent, of course, and got the official approval in our department in Taiwan. So it's available, I think, internationally in the coming few months. Especially for me, when you harvest large volume for like augmentation, mammoplasty. So you are going work very hard to harvest the fat. And with you have to spend more than 1 hour to deliver the fats. It's something got exhausted. So when you have the automatic one, you just put on the trigger. You don't have to pull the trigger continuously. So you just put on and you can go forward and you can go backward to deliver the parcel without any like a manual one. Only you withdraw the gun. So the speed will decrease at least 40% of your operating time. So it's a kind of very a good device for a large volume of fat. And of course, you can use in the 1cc automatic math gun. It's also, you don't have to pull in the trigger. You just switch to the grade, and the fourth grade is 1/240. You just keep it moving, and the fat parcel will come out one by one, continuously without any interruption, like you pull in the trigger. So it's quite convenient and useful. And I will show in the first meeting Bangkok this year.
Yeah. I think, yeah, I mean, I also attended a lot of live surgery with using the MEF gun. I think that is one of the concern of fatigue. You know, when they try to inject manually, I
Yeah,
think you have addressed this concern greatly with your new device, you know.
yeah. Okay.
Okay, is there any question on the floor? Okay. Is there any advice for doctors who wants to start using the MAP gun? Are there any what kind of trainings will be provided, Professor?
Yeah. We have biannually international symposium for master technique in Taiwan, Kaohsiung. And I was very open-minded. If you visit Taiwan, you can come to my clinical to observe my surgery. I think it's kind of very basic instrument. If you want to master the fat grafting, you have to equip yourself. Like something, you go to the war, you go into fighting, you must have some kind of weapon. You cannot use just your hand. Yeah, so this is the reason why we invent buff gum, because I just think that using your hand, you cannot achieve a very consistently delivery of your fat. So one large puzzle end up with the central necrosis, and the large one will interfere with some surrounding tissue. So don't make any mistake from your transplantation. Otherwise, all the effort you make, like from harvest, refinement, what measure, what machine, or what kind of concept you have done, we're going to invent. So I think the mouth gun is the best instrument for fat grafting. And of course, not for only fat grafting. You can use a mouth gun to inject feeder as well. It kind of switch to 1/240, and either any soft tissue feeder will come out with very small. So you easy to deliver the feeder or the hyaluronic acid, collagen, and so on.
There's a question from Jonathan Subecki. The
Yeah.
question here is that to you will be, can you inject larger bolus if combined with PRP?
Uh, in my personal experience, I never combine any other like SVF, artificial stem cell, or PRP. The reason is, what's the ratio? Like in many articles, they say, okay, 1 cc of PRP should be ratio to 9 or 10 or even 20. Okay, I have no idea which the proportion is the best. However, how could you mix 1 cc with your 9 cc or 10 cc or any other your fat puzzle evenly? So if you cannot make it evenly, all the fat parcel is not equally distributed or with the benefits from the PRP. So this is something my personal concern. Like a Professor Yoshimura say, okay, the CLO is very good. Personally, I regard it the best combination of regenerated cell. Okay, SPF are AC with some fat. Okay, SPF, as I can showing you earlier in the slide, is a pellet. It's only 1 or 2 millimeter. And there is about 200 fat. You know, the fat after condense is quite, its viscosity is quite high. It's not easy to mix your only 2 cc, 1 cc of SBF to your 200 of fat grafting. So I think this is the most concern for me. And of course, you can use in the double way or three way to mix it evenly. But at the same time, when you shuffling to mix in the PRP or the SBF with your purified fat, it's going to further increase the shearing force. So the adipose side, even the SBF, we are going to destroy. So personally, I don't add anything in my fat. And if your country is allow doctor to using like a PRP or like a SBF, I have no objection. But be careful. You're just thinking about how to mix these two components equally. If you cannot make it equally, you cannot predict the benefits from anyone you add it to your fat grafting. Okay. This is my personal concept.
Yeah. And Professor, I have one question because nowadays injection of SVF or injection of even nanofat to joint, do you use a MEF gun to inject to the joint?
We are not allowed to inject fat to joint. Actually, I must got some, like IRB or under clinical trial on that. So Taiwan, we have some open-minded from our government to using like adipose stem cell, but you have to find a qualified laboratory. This is not something that you using your fat and processing in your operating room, and you can inject. This is illegal, at least in Taiwan.
Okay.
So I know that so many doctors use it, but officially I don't recommend because they are something you don't understand how complicated the processing, like a septic. There's just a few months ago in Japan, someone using stem cell, I don't know what kind of stem cell, end up with the patient die. So the Japanese government strictly regulates the application of stem cell. So this is something we must put the highest level, especially we are clinical doctor. We cannot just under some concept or read some article and we follow the procedure. Unless you got IRB, unless you have clinical trial in your hospital or in your university. Otherwise, I don't think it's a good idea to inject any kind material that is not allowed to inject to the joint.
Okay. Thank you very much, Professor Lin. I think we are at the end of the webinar. I think my sincere appreciation for Professor Lin for taking his Sunday off and to all the participants also taking your precious time to join this webinar. As again, moving forward from here, we will like to welcome all of you to join the FEST Bangkok that is scheduled on the 28th to 30th of June with all the various international renowned speakers, as you can see from our page here. Okay, then yeah, we can see the main congress and 28th to 30th of June. And we also have a post-conference hands-on cadaver masterclass on the 1st and the 2nd of July. All right. So with that, thank you very much, everybody, for taking your time off for this event, for this webinar that we feature Professor Lin Tsai-Ming. So with that, say, Dr. Lin, and good
Thank
night to
you.
everybody.
Thank you,
Good night.
everyone.
Good night,
Thank you.
everybody. Yep. Thank you.
Bye.
Bye-bye.
Bye-bye.